And you're live.
All right, thank you. And good morning, everyone. It is January 20th, Inauguration Day in Washington, D.C., and a historic day for all of us. It is also the Senate Health and Welfare Committee meeting, and we are happy to be here. We just met with House Human Services and House Healthcare to hear about the new federal funding that will be coming to us soon. Well, it started to be here already, but hearing about the guidelines. And then at 11 o'clock, we have members of the Green Mountain Care Board coming in to give us Green Mountain Care Board 101. And I know that some of you have already talked with folks, but we're going to do that as a committee. So before we get to the Green Mountain Care Board, I thought it would be helpful to hear your thoughts about what we just heard from Steve Klein and Sarah Clark. And if you have questions, would like to have further clarification going forward, just to say that the money will be, and the policy for the appropriation of that money will be on our agenda a lot. But there may be specific questions that you have at this point or comments. Go ahead, Senator Hardy.
Thank you. I guess my two comments was, one, there seemed to be a lot of questions about housing and the sort of interplay between housing and health and welfare issues. So I know that Senator Hooker had one of those questions, and wondering if it might make sense to do a joint thing with our Economic Development Committee about the particular impacts of housing and how it overlaps with the two committees. Then my other comment was just trying to get a sense of how all of this influx of federal money in combination with the pandemic obviously have impacted our sort of regular quote unquote state programs. Like, what is the caseload? How is caseload for various different programs increased, like SNAP or whatever? And are the funds meeting that new caseload? And what can we it's sort of along the lines of, I'm thinking out loud, but sort of along the lines of the question of how do we work for the long term? Like, how has this changed our programs and our response to quote unquote normal times? And how do we adjust right now during the pandemic and moving forward with any of those programs? And that's vague, I know, but that's sort of where I'm.
No, it isn't vague. I think it's a really good question and comment. The issue is that gaps have been identified during the pandemic, and childcare is one area that we're all very sensitive to, and whether or not the money that we have has plugged those holes or not, and then what do we need going forward to ensure that we have a stable system. And it's not different from some of the things we learned about hospital and other provider stabilization needs. So those are excellent questions, and those are some of the things that we will get at. But let's hope we'll get at those. That relates very much to the question I asked Sarah Clark about acute versus chronic needs and how we deal with that. So it's a good question. And then the housing piece, there is a housing day a week from today, and I believe we'll be talking about having some kind of joint meeting with economic development. Whether that satisfies all our interests and answers all our questions, I don't know, but that will be happening. That's good.
And I think, as Steve Klein suggested, maybe we'd want to hear from ACCD about what's happened with housing money as well. And that could be a combination with economic development, I'm sure, because I know that, there was a lot of work done there. And certainly it is something that, housing first. I mean, it just tells us that we need to keep an eye on that so that our health and well-being will be better in the future. And I'm glad Senator Hardy voiced the questions, because I know from the beginning, the point of utilizing the CARES fund was to use them in such a way that we could have long-lasting effects. And I'm hoping that the money is being used in that way. I know that it can't always be carried forward. It can't always be used for the things that we want it to be used for, but what can we use it for that will make those things better in the future? So.
Good. Yes. And economic development has been very helpful in that area. The getting housing for those who are homeless, moving people from hotels to more permanent rental and other housing. So we'll try and get up to speed on that, just simply in terms of our area of responsibility. We'll do that. And that goes for mental health, folks who have mental health issues and substance use disorders, and how we, and transitional housing in general. Senator that's better. There you go. All right. Senator Terenzini, any thoughts or questions? That was a big load to to have.
Well, it was like trying to drink out of a fire hose, really. Yeah. I mean, it's just so much to take on. I took a lot of notes, and it was good discussion. I don't have anything at this time, Senator Lyons, to add. I'm listening intently and just trying to, understand.
So, and that's a good thing. I would suggest going to the joint fiscal webpage and looking at the pandemic information that Steve Klein has on his handout. So when we get his handout on our webpage, there are links to Joint Fiscal Committee, and it will have not just the pages that he was referencing, but some other information that is extremely useful. And we'll try to, and
I do want you.
Go ahead.
I was going to just say, I do want you to know, Senator Lyons, that today is my lucky day. This is the second time I've been with Kevin Mullen. So
that's all of our lucky days. That's good. Let's go circle back to anything else, Senator Terenzini?
Not at this time, Senator Lyons. Thank you.
Okay, terrific. Senator Cummings, any comments? Since you are on joint fiscal, at some point, conversation as we move along, I don't know how important the conversation will be about how the money is being appropriated. We did a very smooth job last time working between appropriations policy committees and joint fiscal. So I don't know that we have the same questions that House had. You're muted.
At this point, joint fiscal, other than to accept grants, really has no role. The various laws we passed last year said that, unless there's an emergency that can't wait, things will go through the appropriations process.
Yeah.
And there is no one big grant like last time that came to the state. This is all going to specifics kind of outside our control. So yeah. I don't think joint fiscal is going to have much of a role at this point.
Well, and as you're saying that, since it's going to be outside of our control, probably more administratively determined, it will become important for policy committees to be fully engaged.
Yeah, because there's no state granting to businesses. They have reopened the PPP grant loan system. That might be something I'm going to want to monitor because there were concerns about who got those loans last time. But but then there's probably going to be another round of funding, and who knows?
I know. I started looking at that and I said, no, let's just stick with what we know we're getting.
Not right now.
Not right now. So last comment is, as we're talking about the funding that has been passed by Congress, the old funding is CARES funding, and the new funding is called new federal funding. So it's not a CARES Act because it was, as Steve Klein mentioned, it's embedded in the budget. So, well, it's all mixed together. Let's say that. So there we are. And so thank you all. Those are good suggestions, and we'll try to keep those in front as we're looking at the issues we're going to cover in the committee. Housing sounds like an important one to us. Okay, so we are very fortunate to have another member of the Rutland area with us today. The chair of the Green Mountain Care Board, Kevin Mullen, and then his executive director, Susan Barrett. Thank you both for being available. And we're going to get an overview of the Green Mountain Care Board. So I'm just simply going to turn it over to you. I do know that members of this committee have met with you separately, and others will be doing that. It's very important for us to have a grounding in the Green Mountain Care Board, as well as some other areas that we're going to be looking at during the next several weeks. So thank you for being here. And it's all yours, Chair Mullen.
Well, it's our pleasure. For the record, Kevin Mullen, Chair of the Green Mountain Care Board, and
Susan Barrett, Executive Director of the Green Mountain Care Board. And I'm realizing now I sent the slides over to Nellie. Am I supposed to share the slides, or I don't know?
I think that Kevin Mullen, Chair Mullen is now can share the screen, and Julie Tucker, can you give?
And I can share it if Kevin can't.
Right. Julie, are you there? Can you give?
Yes, I've given.
Susan?
I have given both witnesses ability to share.
Terrific.
Okay, let me get this up because this is always my challenge. I did not learn this in law school, how to share screens.
So while you're doing that,
So
I'll just
Kevin
get started so we're not wasting anybody's time. Thank you all, Senators, for the opportunity to come in and talk about the Green Mountain Care Board this morning. And it's a pretty momentous day in this country. And so we know that sometimes people's thoughts might be elsewhere, but we're glad to be here this morning, and also want to make sure that each and every member of the committee knows that if you have any questions or concerns, feel free to reach out to any of us at the Green Mountain Care Board, and we'll try to get those answers for you or provide you with some research that may help in whatever you're working on. The Green Mountain Care Board was part of Act 48, which passed in 2011. And basically, at the time, it was thought that it would be better to have an independent body so that there weren't wide swings in healthcare efforts, changes of administration. And so it was patterned after what was then called the Public Service Board, now the Public Utility Commission. And at the time, providers were coming in and really expressing a fear of having only 3 members of a board making large decisions. And so it was decided at that time to create a 5-member board. And the board was created with staggered 6-year terms. And the slide that Susan has up now shows you the current makeup of the board. We have, besides myself, we have Jessica Holmes, who's an economist from Middlebury, Maureen Yusufer, who is a CPA, former CFO of 7th Gen and on several national boards. We have Robin Lunge, who the older members of the committee will remember from her days at Ledge Council, but also in her days as head of healthcare reform for Governor Shumlin. We also have Tom Pelham, who has a wide variety of experience in state government, starting with being a housing commissioner, being the commissioner of finance under Howard Dean, being the tax commissioner under Jim Douglas, and he also served a brief stint as assistant secretary of the administration. So this board is tasked with several things, and if you take a look at what was happening prior to the creation of the Green Mountain Care Board, we had seen several years of very dramatic increases in healthcare expenditures in the state of Vermont. We had gone from a little bit over 11% in 1990 of the state's GDP to approaching 20% when the board was created. It was around 19% of the gross domestic product. And certainly that's an unsustainable path. And there was concern that it was making healthcare unaffordable for Vermont. And that's been a theme that's been echoed. I like to tell the story about someone who called into the radio show and said that they found a pamphlet from 1935 that talked about the biggest problems the state of Vermont was facing and what needed to be done. And they were talking about education, healthcare. So no surprises, this discussion has been around for a very long time, but we have to have a sustainable path forward on healthcare. And it was envisioned in that act that it wouldn't just be about cost containment. So the board is on a 3-legged stool of cost containment, but also increasing quality and increasing access to care. So we're very proud that Vermont usually gets ranked first or second when it comes to health outcomes around the country. I wish we could say that we were the lowest cost state in the country. We are not. And there might be some advantages to not being that lowest cost, because we probably wouldn't be ranked first or second as far as health outcomes. But we still have to make sure that we're on a sustainable path. One of the charges of the board is each year to provide a health expenditures analysis. And because of lags in reporting and, basically some fights over claims for payments between payers and providers, we're usually about 2 years behind in our health expenditure analysis. So the most current one that's currently available is 2018, but within the next couple of months, we'll have 2019's health expenditure analysis completed for your review. I hope that it continues to show what we saw in 2018, because what we saw is previous to that, Vermont was about 2 percentage points higher than the rest of the country as a percent of their state's economy. And what we saw in 2018, we were only 1.5 points above. And so that was a step in the right direction. We're hoping that that wasn't a 1-year blip and that we see a continuation in that pattern in 2019. But the proof will be in the numbers, and we should have those for you in a couple of months. Susan, if you could keep the slides going.
Yep. And I think I was going to do the next. Oh, did it? There we go. Should I take this one, Kevin? Is that good?
Sure, go ahead.
And thank you, everyone. It's nice to meet you. I shared this with Senator Lyons. We've met individually with Senator Terenzini and Senator Hooker, and we're going to meet individually with Senator Hardy next week. So this is in addition to that meet and greet, and it's a really nice opportunity for us to give you a general overview of the board And I'm sure, as Kevin said, if there's continued questions, we can come back and we're here to support you. So this slide really just gives a general, what is the Green Mountain Care Board? And our mission, and Kevin touched on this, is to improve the health of Vermonters through a high quality, accessible, affordable, and sustainable healthcare system. And there are three things that make the board really unique across the country. There's nothing really like it in any other state. Number one, we're transparent. We are guided by Vermont open meeting law, which is often, for me personally, sometimes a pain in the neck, but it is a real advantage to Vermonters. And I think, and I believe it makes our work better. So all of our meetings are public, they're publicly noticed. All of our decisions are made in public with data, evidence, and staff recommendations. And I would say, instead of nearly all of our decisions are made in public, we have deliberative authority both in rate review and in certificate of need, but everything else is done in public. If you ever want to check out our meetings, they're available through Orca Media, and that can be found on our website. And then lastly, we're very transparent in that we engage stakeholders. We work really closely with the healthcare advocate. They are great partners in our regulatory work. And then we also work with other state agencies, regulated entities, and of course the public to inform our work. Kevin mentioned the independence. The board members have 6-year staggered terms, so they're often span gubernatorial administrations, which is a real benefit. And then this is a real boon to the board, is we have a system-wide view. So our unique role in Vermont's healthcare system is that we regulate key industry players, we drive reform efforts through our regulation, and we evaluate our healthcare system. And then we also take a very integrated approach. And there's some resources later on in the slides. We've done some work on regulatory integration and really moving towards having our regulatory processes inform each other. This slide, and I won't go through it in detail, but it talks about on the left side circle is our statutory charge. So the Green Mountain Care Board is charged with reducing the rate of healthcare cost growth in Vermont while ensuring that the state of Vermont maintains a high quality, accessible healthcare system. That's our statutory charge. It's the triple aim, essentially. These on the right circle are most of our duties. We're going to touch on those in some of our later slides, so I won't go through them now. And again, just to reiterate that system-wide focus, the board oversees innovative reforms that seek to improve the quality and access of care. We contain Vermont's healthcare cost growth. Kevin touched on that as well. The board looks to improve Vermont's ability to collect and evaluate healthcare data. I think you'll see later on in the session when we share some of the work we're doing on sustainability, how we're using our data in ways that we've never used it before. So I think you'll be pleased with that. And again, I touched on this as well, promote transparency and understanding of healthcare. So now I'm going to turn it back to Kevin, how GMCB helps Vermonters. Kevin, you're on mute.
I often wonder how it can mute itself, but it seems to happen with regularity. Okay, if you could advance the slide once. Susan? Okay, so, basically, every day, our mission is to make sure that the value we provide for the cost of what we do exceeds that cost. And so the value that we're looking at is trying to make sure that Vermonters have the right care at the right time and adding the third right in the right setting. And so what you see, some of the advantages of trying to move away from the state's the state currently has a strategy, which is to move away from fee-for-service to value-based care. And what you see by that strategy is trying to take out some of the inefficiency in the system. So for example, prior to the all-payer model, if you needed to go to a SNF for rehab, you were probably held in the hospital for 3 days to make sure that your stay in that SNF would be paid for. And the all-payer model allows for that inefficiency to be taken out. It also allows for some really savings for providers by not having to go through as rigorous a prior authorization process as they normally would have to do. And so those are the type of things that we're trying to do as far as moving away from fee-for-service to really value-based care. And for care to really work, we need to make sure that it's coordinated care, because it doesn't do any good to release somebody from a hospital for a couple of days and then have them back in that most expensive setting quickly. So if you can coordinate the care once they're leaving the most expensive setting so that they have the home visits via VNA, they have the right nutritional advice, they have the right set of people looking in on them, it's cheaper overall, better for the patient, and much more of a cost saving for the system as a whole. And we're really seeing some movement towards that. So we've heard success stories where within a given provider practice, a social worker has been embedded that allows them to work with the Vermonters who need that assistance. So you're not seeing somebody that is just calling on medical care because they really just want to have somebody to talk with, and things like that. And so there's value if everything is done in a coordinated fashion. And that's a key goal. And in order to see success, payers and providers have to be held mutually accountable for the quality and cost of care that they provide. And that isn't always easy. People are hesitant to change. We all are a little bit leery of changing the way we do things, but over time we're seeing that movement. And if we can just keep moving in that right direction, we're going to have some innovative reform in Vermont. So if you could go to the next slide, Susan. So if you take a look at this slide, this is really taking a look at our regulatory processes that we have, whether it's health insurance premium rate review, hospital budget review, certificate of need, or oversight of the accountable care organization. We're always trying to push that reform effort forward. We don't want people just to say that they are part of the all-payer model, and yet they haven't changed the way they do business. And too large a percentage of what is still happening today is still tied to the fee-for-service world. And we continue to push people to move away from that and to really move towards value-based care and trying to keep the patient healthy rather than rewarding providers for every time that they do a procedure or a test that really is indicative of an illness that you don't want to get to. So I love to tell the story about one of the first field trips that I took as a member of the board was to Brattleboro Memorial Hospital. And they were very, very proud of their wound treatment center, and justifiably so. It's a great treatment center with the hyperbaric chambers and everything to treat the wounds. But when we asked the question, okay, this is good because you're preventing the amputations, but what are you doing when somebody's pre-diabetic in a physician practice to try to help change their lifestyle patterns so that they never even need to come to a wound center? And, the eyes kind of glazed over. And that's what we're trying to push with this model, is to, take a look at the types of illnesses that are very costly to the system And those chronic illnesses, if they can be prevented or managed earlier on, you don't see the type of outcomes that you would have in a traditional fee-for-service world. So you want somebody to get on a healthy diet and exercise and try to keep them out of becoming a full-blown diabetic and out of having to worry about possible loss of eyesight or loss of a foot or what have you. Same is true with hypertension and other chronic illnesses. So with our system-wide view that we have at the Green Mountain Care Board, we're able to try to integrate all the different pieces of the system together so that a decision made in hospital budgets should carry forward to a decision made in rate review and vice versa. And some of the barometers or measurements that we like to look at from 2013 to 2019, our health insurance premium rate review process reduced those premiums by approximately 108 million. I don't like to use the word saved, even though that's the word on the slide, because then I get into a debate with our insurance colleagues about whether we've deferred or saved. I believe that we have saved, but I'm not going to get into that fight with them over the use of terminology. And in the hospital budget review process, you've seen that prior to the Green Mountain Care Board, the period of years where those costs were growing at 7.3% as opposed to after the implementation of the board where they've grown closer to 4%. So if you could go to the next slide. So this is just a slide view of the hospital net patient revenue growth over the years. And you can see that prior to the line for the start of the Green Mountain Care Board, it was a much higher growth in costs. And if you go to the next slide. So one of the biggest things that we have been striving for in recent years is to really improve the data collection that's available at the state level. And the Green Mountain Care Board houses the two main databases for healthcare in the state of Vermont, looking at both the provider view and the patient view. And that is the all claims database and the hospital discharge database. And through that, we're able to take a look at how Vermonters are accessing care and the quality of the care that they're receiving. We're also able to look at what is driving healthcare spending. So you can see that in recent years, what has been driving the increases has been a number of factors, but two of the biggest factors have been an increase in utilization, which means people are seeking more care. And what we know from a lot of academic studies from Dartmouth and other places is that more care does not necessarily equate to better outcomes. So you need the right amount of care in the right setting. And what is driving that healthcare spending? So for example, we know that prescription drugs have been driving a good percentage of the increase in costs. And when you bore down more heavily into that, it's really specialty drugs that are the huge cost drivers to the system. We're able to look at the effectiveness of the reform efforts that have been put in place and realize that there's so much more that needs to be done. And this shouldn't be bulleted, it should be a separate paragraph on this slide, but we're currently pursuing funding either through the budget process or through a grant process that we're working on right now to update rules to improve collection of data to require the reporting of race and ethnicity data. We know that there are disparities that exist, inequalities, and part of the problem is that under the current rules, the people inputting the data are not required to input those fields, and we want to make those changes so that we can be agents of change to make sure that all Vermonters, regardless of what their ethnicity is, are getting the right type of care. So if you can go to the next slide. So we really believe that a major part of our mission is making sure that Vermonters have access to everything that is happening in the healthcare system and can understand it. I do feel that this is an area that we fail to achieve our goals on. Unfortunately, very few people read one-pagers or things that are done, but we try to continually get the message out there and encourage others to do that as well, so that people understand what is driving healthcare costs, what they can do differently to try to make changes in that, and what they can do differently in their own lives that could have major differences in the health outcomes that they achieve. All of our public meetings are recorded, and Susan has provided the links to that on our website. And a big part of our process is putting out for public comment almost everything that goes before us for decision making. So we're always receiving public comment. We take that very, very seriously. I know that we've been criticized for not responding to every public comment, but just to give you an example, in the last QHP rate review, we had well over 750 public comments. And so it makes it impossible to reply to everyone, but it's mandatory that each and every board member reads each and every public comment. So we take that very seriously. So Susan, I'll turn it back to you.
I'll unmute here. I had some barking dogs in the background, not an unusual thing during these pandemic meetings. So this is our last section, and then we can open it up to questions if the chair would like that to happen. So how does the board support state agencies and the legislature? We have regular reports in our statute that we provide to you. Kevin discussed one, the annual expenditure analysis. There are other reports that we have that we submit to the federal government, for instance, on the all-payer model. And we always supply those to you as well. Most recently, I think it was last year, the healthcare spending, primary care spending analysis per Act 17, we shared with you. I will put a little plug in here that there is a New England group that has done some health primary care spending that they produce. They're called NESCO. It's a New England collaborative. I did share the information with Senator Lyons when they shared their study with the board. I can follow up with that as well. I think that's going to be really interesting work that builds on some of the work we did in the primary care spend report. We, as I said, I mentioned the Vermont healthcare expenditure analysis. We provide data on healthcare quality and access. And then we also provide information for potential policy options. We led the rural healthcare task force that was implemented or put out in statute. I think it was the year before last. Board member Lunge did an amazing job with that work and working with other stakeholders in the state. And as I mentioned earlier, you'll have some forthcoming reports on provider sustainability and reimbursements from us.
And one thing I just want to throw out before you
Sure.
go to the next slide is anytime that you want a deeper dive into specific areas, our staff would love to come over and basically show off the work that they've done. So for example, Lori Perry would love to come to the legislature and talk about the health expenditure analysis. Michelle Degree would love to come over and talk about the work she's done with NESCO on the primary care spend. And Patrick Rooney would love to come over and talk about the analysis of the Brattleboro retreat that he most recently completed. I mean, those are just three examples, but we love to give our staff the opportunity to have a stage to publicly show their value as well. And we've got some great state employees, and anytime that you can get to spend time with them to take a look at the work that they're doing, it's greatly appreciated by them because they see that the legislature sees that they have value.
Thank you, Kevin. And then lastly, we convene stakeholders and collect feedback. Kevin mentioned the public comment periods and working with our public stakeholders, but also our regulatory stakeholders. We lead efforts to engage stakeholders, to gather information, to provide feedback, to inform folks like you as well as other state agencies. Some of the areas that we've worked on are, and we have technical advisory groups on many of these areas. So for primary care, I mentioned the Rural Health Services and the Rural Health Services Task Force. Healthcare workforce, also big part of the primary care advisory group work. Healthcare reform, planning in progress, and the prescription drug prices. We are currently underway with a technical advisory group on the prescription drug issues at the state level. So stay tuned for some results from there too. And then last, I just listed our priorities. We can go through these quickly, and then we'll finish up here. But our first priority is the implementation of the all-payer model. That is with our partners at the state, AHS, and the executive branch. We are 3 co-signatories on that model. So I want to make sure that you know that that implementation of the all-payer model is a very high priority. Also, the oversight of the Accountable Care Organization, that is the vehicle by which that providers participate in that model. Regulatory integration, I touched on that. We are really working to bring together our regulatory duties and so that they can inform each other. And our white papers are linked on our last slide, so you can have a look at those. It would be a great way to learn about the work of the board if you do take a look at them. We touched on transparency, data, VCures 3.0. The health resource allocation plan, this is another duty of the board. It's in our statute, but a couple of years ago, we were asked to update the health resource allocation plan. That's something else, as Kevin mentioned, to have folks come in and share updates with you. Our staff, our data team, Jessica Mendizabal is leading that work. It has done an amazing job, and those updates are on our website as well. Healthcare workforce, Kevin has really done a lot in focusing on healthcare workforce. It really does impact the cost of healthcare, as we see in hospitals when they have to pay premiums for traveling nurses and providers. And then last, but certainly not least, is hospital sustainability. We're working with all of the Vermont hospitals, 14 hospitals, on future sustainability plans. And stay tuned, we will be in to give you updates on that as well.
So I guess we'll open it up to questions if you allow that, Madam Chair.
Yeah, absolutely. And this is so chock full of information that everybody's going to have 1,000 questions. I just do want to comment briefly that we will get staff in to talk about some of the reports that we've asked for. The one thing I want to share with the committee is how collaborative we have been in working with the Green Mountain Care Board. So when we write a bill, a legislative request, for example, to look at hospital sustainability planning and funding issues, that we did that in conjunction, not just with the hospitals, but very much with the Green Mountain Care Board, who understands what hospitals can and cannot do. So we'll look forward to the reports that you've talked about, whether it's a sustainability planning, the NESCO report, definitely to get an update on where we are with our primary care and prevention. And as we look at healthcare reform and the all payer value-based payments. And I'll ask a question up front, and then that would be a question that you guys can help us answer. And that is, during the pandemic and during the healthcare stabilization funding, so money that has gone out to providers and hospitals to ensure their stability during the pandemic. And that includes DAs and SSAs, our designated agencies like Howard Center and so on. The payment for services has very much been an all payer, a payment per member per month. And it's worked. It's been extremely helpful. But it has not, all of it has not gone through the value assessment. So the quality data analysis. So there hasn't been data collection about the effectiveness of some of those all payer funds. So the question that that we want to get at is, can we expand all payer and ensure that we have quality metrics in place? That for some people on my committee, that's a pretty wonky question to ask right now, but I think that you guys at the board probably understand the question, and maybe we can at some point circle back to that one. And I'm not going to ask any more questions right now. I'm going to let the committee ask their questions. Sorry.
So on that particular question,
Uh-oh.
I think that whether you're a fan of the ACO or not, what we're getting is general buy-in in the state of Vermont for moving away from fee-for-service to value-based care. And that's the most important thing, that we start that transition. So it's a very all-encompassing question. And part of the problem that Vermont faced, just like everybody else in the country, when those dollars came in, there was a very compressed timetable. And without those dollars, there would have been huge problems, possibly hospital having to close their door. But because of those dollars, and it's easy now for me to look back and say, well, the federal government should have done a better job to better allocate the scarce resources. But if they took the time to figure that out at the time, I think there would have been casualties along the way. So I'm still of the opinion that the federal government did a good job getting the dollars out, and the state of Vermont did as good a job as it could, given the rules that the federal government were giving them at the time, even though they've been relaxed somewhat now. So, that measurement process will play out over the next few months, and we'll see how successful those dollars were. But without those dollars, Vermonters' healthcare would have been in jeopardy.
Absolutely. And then the question is, going forward, when we're no longer receiving those dollars, how do we keep in place the all-payer model for all of those providers who were receiving the all-payer model monies, the value-based payments, and ensure that we are getting the quality information that we need? So that's the next step question. And I've been asking this for a long time now, but we'll just keep working on it. But I know Susan knows I've been asking it. Probably you do too, Kevin. So committee questions. Senator Hardy and then Senator Terenzini.
Okay, thank you, Senator Lyons. And thank you, Kevin and Susan, for your presentation. I have a lot of questions, so but I'll just ask a couple, and then maybe I look forward to our conversation next week. there's just a lot to learn in this area. But my general questions are, and I think, you know, this may be more of a comment for the chair. I think an overview of the One Care and the ACO and how that works and how that relates to the Green Mountain Care Board would be really helpful. Oh, Senator Cummings is trying to get our attention. You're muted, Ann.
And Senator Cummings, you're muted, and
Okay.
Senator Hardy.
I'm stepping out because we are swearing in the first woman vice president of the United States as we speak. I love the Green Mountain Care Board, but this only happens once.
You may go. We're gonna finish up pretty quickly so that people can do that. Yes, I agree. It's a
Yeah,
phenomenal.
I agree. So maybe I'll just list my questions so we can get back to them. The ACO.
So can I just say, Senator Hardy, any requests that you have for learning more about the ACO, certainly that's on our agenda. We will be looking at that. And so just put that onto your agenda list for me, please. And then we'll just keep focused here on the Green Mountain Care Board.
Okay, well, I guess I don't understand the relationship between the Green Mountain Care Board and One Care, and what I mean. So to the extent that you want to answer that question, or if we all want to leave and go watch the inauguration, I don't know what the plan is right now, but that is something, you know, that this issue is very at front of mind for a lot of people who are following healthcare reform. And I've heard lots of conflicting things. So I'd love to hear your take on it from the perspective of the Green Mountain Care Board.
I do not mean to interrupt, but this is a long answer. I know that there's oversight the Green Mountain Care Board provides for the ACO, and then we'll come back to that question. So just in terms of the duties of the board and what they do to keep it pretty low key for today. And Chair Mullen, you were chomping at the bit.
I was just going to say that basically the all-payer model agreement, which is an agreement with the federal government, the reason why the federal government was willing to do the Vermont pilot was really they liked the fact that there was a board that could be the regulator in the process to try to make sure that the accountable care organizations were delivering what the federal government hoped for. The feds have always wanted more than one accountable care. In Vermont, it's hard to make an argument that you'd get a lot of benefit because of the infrastructure that's required to have an accountable care organization, and with such a small population, it would be different. But basically what our role is, and it's actually more than just the all-payer model, it's more of what the legislature put in place in Act 113, which would probably be a good thing to have some time with the committee on too. And Act 113 requires that we approve a budget for them and do the oversight for that. So we're kind of like the people overseeing to make sure that there's value from the accountable care organization. And I think that if you could allocate some time, Chair Lyons, a couple hours, maybe we could bring in Elena Barabee and others to really do a primer on what the all-payer model is, what One Care's role in that model is, what the Green Mountain Care Board's role is, what AHS's role is in that. And it's going to take a lot more than a few minutes here.
So yes, absolutely. That's what I was suggesting earlier. We will take time to dive into the ACO, and we've had folks in. We also, as a committee, last session took a little field trip to visit with the ACO. Now, whether we need to do that again, I'm not sure given COVID, but so we will take time to evaluate the ACO. We will look at what it means for what the quality metrics mean. What do our community connections mean? How do we move away from fee for service? How do we integrate geographically dispersed services and so on? So there's a lot to do. And this having Green Mountain Care Board in gives us some insight into the oversight of all of these healthcare issues, and the link between Green Mountain Care Board and our AHS in the waiver, the all-payer waiver, is important. So we have a lot of ground to cover with new committee members, and we will persevere. And we'll do it. We're gonna be filling our brains. It's great.
So can I just list my other things, and you don't have to answer them, and then just so you maybe this as a heads up for next week, and then I'll cede to Senator Terenzini. But the other, I think a lot of people mix up or confuse the difference between the Green Mountain Care Board and One Care and think they might be the same thing. And I know they're not, but when talking to constituents, that's a common confusion. And then the other topics that I'd be interested to hear your take on are the teachers' healthcare situation. That's a huge thing for most of our school districts, and I'm assuming you have opinions about that. The other thing is, and Senator Lyons already alluded to this, but the sort of impact on the overall healthcare system because of the pandemic and what your data is showing about that. I know that our stability of our small hospitals is in jeopardy, and that concerns me here in Addison County. And then finally, another topic that comes up that I hear from constituents a lot is the concept of universal primary care as a sort of starter into universal healthcare just in general, and how that fits in, if it fits in, where it fits in with the all-payer model. So maybe that's just a preview for our conversation next week, but that's what I have.
We look forward to it.
It's going to be a long conversation.
Yeah, me too. We only have a half an hour. Maybe we need a couple hours, but thank you.
Good. All right. Senator Terenzini.
Thank you, Senator Lyons. And thank you to Susan and Kevin for meeting with me early this morning. It was very informative, and appreciate it. I want to respect the committee's time because I am aware of what, obviously what today is. And but for another day of conversation, Kevin really sparked my interest this morning. And I think I'm optimistic, but I think it's something that this committee, if everyone agreed, could help solve. And we heard it yesterday again from the president of UVM and our education committee, that there's a real disconnect between placing nurses from school for their clinical training due to the lack of enough nurses that have the master's degree certification to train them. And so we talk about a nursing shortage in Vermont. We talk about what we heard from UVM yesterday. Myself, Senator Lyons, and Hooker heard that UVM could triple the amount of students that they graduate every year, and yet there aren't enough clinical placements for these nurses. And that master's degree designation for a trainer is a stumbling block. So anyways, conversation for another day. I want to respect everyone's time, but if we could put that on the list of things that maybe we could accomplish with Kevin and Susan to solve one of our state's biggest problems right now in the medical field. So that was it.
Senator Lyons, we started to talk with Senator Terenzini this morning about the bill that was passed last year and how it was a step in the right direction, and really the pressure needs to continue in that direction. So if you have the time, and I realize that your time is limited, but if you have the time, when you have that conversation, if you could bring all the players to the table, it would be great, like the Secretary of State's office and people like Laura Pelosi, Joel Olson, people like that, and just have that conversation about workforce, because it still continues to be the biggest problem that we have in the system.
Good. Yeah, that absolutely. We completely understand that. And I know that we're going to hear from people who are watching in right now about nursing, and we do have a nurse compact bill that we'll be working on in our committee. So we'll hear again from Laura Pelosi and Joel Olson and the whole crew who did so much work on the Rural Healthcare Task Force, and you also in your workforce initiative. So thank you for that. All right. So will you see, when you begin to see the tip of the iceberg, some of the stuff that's under the water starts to show up, and you all of the questions that we've heard today lead us in to go under the water and look at the whole thing, and that's what we'll be doing. So we're on our way. Thank you both for being here. I am very sensitive to what's happening in Washington, D.C., and thrilled that it is happening. So I think that we will end the meeting now. Thank you both for being here, and we'll be asking you and some of your staff in to bring us up to date on some of the studies that we've asked for. So thank you.
Well, thank
Thank you so
you
much.
for all your public service, and anytime that you have any questions, we're available.
Absolutely.
Oh, good. Well, you've heard 100 of them, and you're going to get hundreds more. So
Yep.
Thank you.
take care.
Thank you very much. Everyone should watch the historic events. First female vice president in the USA. Yay. Thank you all. Woohoo!
Julie, you can end the meeting now.
One moment.